11.
Good to go.
All right, good morning. This is Senate Health and Welfare. It is Tuesday, April 11th, and we're starting our meeting. And on Friday, we heard from a number of folks regarding budget type requests that are in our area. And these are mostly requests that were not funded by the House in the budget or that were underfunded. And Nolan,
Actually, I made better copies.
Oh.
Those are all.
these are old no?
No, see how the ink just melted away on that one?
Oh,
Pretty
so much better.
So much better, right?
Oh, thank
There's
you.
an extra one for, oh, you made copies.
We haven't handed those out yet, so what I'm gonna do is hand out what Nolan has prepared for us based on the testimony that we heard.
It's mine.
Oh,
Would you like me to move it? Yeah.
Here,
can you do that?
take one
I'm sorry.
Okay.
and pass the others around. And we are actually meeting right now, and we are not on P22, we're looking at some
Sorry,
budget
Senator.
information. Nolan, do you want to sit up here? Is it, or,
Sure.
okay,
Voilà, madame. And
so, last year, when we went through the budget, we had a number of bills that we were looking at. We put the bills in with this document. And then I asked Nolan we heard from folks and we put all of the sort of requests in together. So what's not here is S56, with the childcare bill, a little difficult.
Well, partially because the budget's already made assumptions about it.
Yes,
So, and that's already out. So this is just the list of all the people who came in and what they asked for, the requests. And so I just put it all in one place. Last year we added the bills to it too, but I just did for
yes,
to the time.
okay. So just, here's my suggestion for the list. Let's take a minute
Hey,
to go through.
fine, man.
We should go through.
Oh, that's nice.
I love that you just like that fight for yourself. I
If
would
you
do
were
it
gonna,
for
if
you.
you were gonna say that
No,
to
no.
anyone, that was the
Happy to
right person to say.
Well, I can say Jim.
Okay.
I like him. That's on the record.
We all do. We all.
Can we correct the record? Maybe redact the record?
I'm gonna change my vote.
Change my vote, please.
Oh my
Next time I'm
God.
gonna say,
Okay,
I'm gonna say Senator
This
Hardy.
is definitely the day after a weekend, or it could be a Friday, or it could be a Wednesday or Thursday, we don't know. But
Apologies.
no, don't. All right,
All right,
keep
so I
us
didn't-
all sane.
I didn't add 56 into here because it's already sort of built into the budget construct. And this is all things that are, most of them are not, some of them, if they are in the House version, I've said that they're just asking for you to try to highlight where they said same as the House, or the House did this, but we want X more. I tried to make it as clear as I could based on what information was provided. Most of the people had good written testimony, so I was able to go back and do that. So thanks to Senator Lyons for always asking people to put everything in writing.
So ordinarily, we do send a letter and we prioritize, but I'm thinking that because our time is quite limited, that I'm probably more interested in having each of us identify one or two things that are top priorities. And then we, for the committee. And then tomorrow morning, we'll come back to this and then just send it off to appropriations. So I think that's really our time frame. We have today and we have tomorrow.
So tomorrow we'll
Yeah,
Okay.
we'll try and do it just before we adjourn.
basically just reorder these or something?
If you have some that you feel are priorities
Okay.
for you, and we'll come in and look at those.
And you can tell me which ones you want and
Yeah.
prioritize them, and then I can.
We can send the whole list. There's no reason why we can't do that because they've come in and testified to the need. But there may be some that rise further, go above others, and then it is also really difficult to do this. Really.
Friday was difficult.
Yeah,
And just again, this is just.
Don't worry, you'll get
people-
palace.
And remember, this is just those who came in. I mean, there's other stuff that's in the budget, there's
Right.
other stuff that went to the other committees. These are just the people that.
so basically, if there are funds unexpended, or there is, as we've heard in appropriations, and we went through 2 public hearings, there are over $400 million in requests similar to this. So there's a lot of support needed or asked for in the community. And that one of the pressures we're feeling is the loss of federal funding. So it makes it twice as hard. Oh, is there anything else we need to say here?
The only thing I would say is that when you think about what recommendation you want to make, take note of whether it's matched or not, if you know, and whether you think it should be one-time or base.
Is matched language in here?
Sometimes it'll say general, well, no, you won't always know,
You won't.
not from this.
Do you
And
know?
it's probably.
I know, actually, the reality is I didn't do it because I didn't have lots of time, but Stephanie does know. She can look at this list and know. So actually, you don't have to know. They'll know over there. for their
Yeah,
expansion.
we'll know when appropriations.
But if you, I would say, just think about if you want to be one-time or base, sometimes some of the stuff is grants. Sometimes they want to extend their grant. One of these, it's like they got $1 million and one time, but they want to base. So just, you don't have to answer that, but just be cognizant of those things. That's all I'm saying.
Yeah, if it's asking for something that looks like it's a long-term expenditure, like a position to do X, then maybe, and it's funded one time, maybe you want to think about whether this is a good base funding.
And the other thing I didn't have time to add, tried to do this, sometimes some of the stuff they might, just because they're asking for money, they might have money in the budget, it might be in the governor's rec. So I tried to flag it when I knew it was in the governor's budget and they're asking for more. Sometimes they have base funding and the House didn't do it. Sometimes the governor increased it and the House has concurred. I didn't have time to go through each of those. So, but I think you're working, all right. You're working with the information that I have had at the moment.
Okay,
And if there's
So-
things on the list that aren't, that you want to see added, we can add it.
absolutely. Okay, so just take a look, and if it gets to be overwhelming, it probably will be. But we will come back to it for a few minutes tomorrow before we adjourn at some point during the day.
What's the process if we all come in with different ideas? Do we try to come to consensus as a committee?
Well, if we come to different ideas and there are still places where things are not, those things that we've identified will move up. And the others, so it won't be necessarily a priority list from the committee, but it will be a list of those things that individual or committee as a whole supports. That's probably the best way we can do it at this point. And if we decide everything is important, we'll send the whole list. Well, we will send the whole list. Acknowledge that.
Okay, well, I'm also thinking that you and Senator Hardy probably have knowledge about some of this
Well,
that
yeah,
we
we
might
do.
not have. as
We
well.
absolutely do. And I will just tell you, for example, there's a blueprint pilot program that's only been proposed for funding for 1 year when it's a 2-year pilot. So that one just for me is,
Yeah.
no-brainer.
Yeah,
Anyway,
okay.
okay. We'll see how it goes. Okay, Nolan, anything else? Not as probably coordinated and organized as we would like it this year, but we'll see how it goes.
I think Nolan's products are good.
It's a very good
It's
product.
great.
Always
Brings
is.
us up to speed.
Yeah, the links are good.
Links are good.
Can't wait to look at it. You emailed it to us too, so I can actually click on the link.
It's, if you want to post it, I sent it to Alex. I don't know your name, so I can't send it.
It's
Hayden,
Hayden.
Hayden Ross.
Alex will be back on his computer, so you can post it instead.
Okay, okay, well,
It'll
Yeah,
be on our website. You
It'll
did
be on the
email it to
website.
us.
it's on JFO website now?
no, I've sent it to Alex
Oh,
post.
maybe do that, send it to all of us.
I can send it.
Yeah.
Just curious, is Alex out of pocket, like unreachable, or is he just not?
He's gonna check his email.
Okay, good.
He'll check. And he may be able to post it. So copy him, Nolan, if you don't mind.
Mhm, no problem.
Good point. All right. That's fun. The other thing that I always think about in the budget season is, are we looking at something that's brand new? And if it is brand new, does it reinforce something that we've been doing? Or is it just brand new? Probably better to support the things that have been demonstrated as useful and defensible. Brand new, make it. And then there may be other committees advocating for some of these things in addition to us. See how that goes as well. All right, so we'd like to move on to H222. Can you just check and see if Katie is coming in? And then we're going to, so we'll hear from folks who are here, and thank you for being here. This is great. Recognize all of you. So Tom Dalton is here. So Tom, why don't you come up and
Do you mind if Justin and I come up together?
I don't mind at all. You can put your chair right up.
I'm just there. I'm taller than this. That's a fun
So thank you. And you have looked at the bill. So why don't you introduce yourselves for the record, and then we'll hear your testimony. And do we have it on our webpage? If we don't.
Part of, I
I know
submitted
part of
written testimony, so we have that part, but we're gonna talk about some other things. I could add some written afterwards if you want.
Okay, yes, please, that'd be good.
So I'm
We
Tom.
listen better when we know we're gonna have it.
Okay. Okay. I'm Tom Dalton.
I'm Jess Kirby. Is that all we need to say?
And you work for, your titles are?
Executive Director at Vermonters for Criminal Justice Reform.
And I also work at BCJR, Vermont Criminal Justice Reform, as the Client Services Director. And I'm also a person with lived experience with opioid use disorder. Yes.
Go ahead.
Okay, I'm gonna pass this to you all. It's just to give you a little bit of background about kind of where we're coming from when we testify on these issues, and our closeness with overdose deaths. We've brought some data from our BCJR's Open and New Reentry and Recovery Center in Burlington, and so we brought some data that we thought might be interesting points for y'all to look at that really demonstrates the level of risk, overdose risk, and other risk of the people that we're serving, and a lot of these things, a lot of things in this bill that will help the people that we're working with. So just a little bit of background: BCJR opened a reentry and recovery center for justice-involved people with substance use disorders, most of whom have opioid use disorder. In August 2022, we're working with over 120 people now, and all of whom have some sort of involvement with the justice system and are people who are at high risk for overdose death. One of the things that we've been thinking about is Dr. Levine citing in the opiate settlement recommendations that 75% of the people who experience, of people that passed away from overdose had no prior connection to the treatment system. And that really kind of got us thinking about how so many of them do have maybe not involvement with the hub and spoke system, and like preferred provider type of service, but they are touching the criminal justice system, and those are very high risk people. As we know, over 50% of incarcerated people have opioid use disorder in the men's facilities, and I just learned that it's like over 75% in the women's facility. Also that 75% of people that didn't have a prior connection to the treatment system, that doesn't also capture like harm reduction services like we're doing, people that are touching certain service programs, people that are, recovery centers, domestic violence shelters, so they're, even if people aren't touching always the hub and spoke and preferred provider networks, like they are in our criminal justice system and sometimes touching other services. So it's just important for us to note that. So as you can see on the data point, we're reaching really high risk people. 82% of the people in our contingency management program tested positive for opioids. 89% tested positive for stimulants, and almost 80% tested positive for both. 49% were recently released from incarceration, so very high risk people. 82% reported a history of overdose. 60% had had one in the past 6 months. 4 had had an overdose in the past 24 hours of prior to their intake. And I just wanted to share that like this past week, in the past like 8 days or so, I've become aware of like 5 overdose deaths in Chittenden County that I know have happened, and I knew several of those people, and so we're like right now currently experiencing some sort of that's higher than normal, even in this increase that we've been having. So we recently got xylazine test strips, which we were really excited about. That's like something new, and we knew from working and talking to people that although fentanyl is very prominent and people are expecting that a lot in their supply, that xylazine is something that people are concerned about. We've had a huge uptick in wounds. We have like 3 or 4 people right now that are being treated at UVM for either endocarditis or a serious blood infection related to that. So we've been giving those to clients to test their drugs prior to use. And also we've tested 17 people. They can also be used for urinalysis testing. And in our contingency management program, we do that. And so we've tested 17 people so far. And 11 of them were positive for xylazine, and pretty much all 11 were pretty surprised to really like see that result and know for sure, even though this is something they've been hearing about. So that's 65%, in like the 2 days that we started testing with those, which is really concerning. So, and I also just wanted to let you all know that BCGR does have $150,000 request that's been supported by House Human Services and House Appropriations, and it's in support of our Reentry and Recovery Center. We have some funding from the City of Burlington, UVMMC, and United Way, but we have about $150,000 budget cap, and we don't get any state funding. We haven't been able to get at this point, Recovery Center funding or harm reduction funding. So, we're doing a lot of really great work with a lot of people in just the short time that we've started, and so we wanted to mention that to you. It's a relatively small request, and we know how that can get lost in the shuffle, and we wanted to tell you we're doing a lot of really important work that is absolutely saving lives. Another really quick thing is that 36% of the people that came into our contingency management program that were unhoused are actually housed now, at least temporarily, like in the Burlington Housing Pods or emergency shelter. And in the housing, times we're in, that's pretty good. 36% have, obtained housing, and also 50% of the people that weren't enrolled in MAT or MOUD services are now enrolled since intake. So we're really proud of that. We wanted to come and, tell you all how much we appreciate like the hard work that's been done so far on H222, and say that we really appreciate the legislative focus on reducing overdose deaths and on all the work that's been on this bill. We think it's very important. There's nothing that we oppose. We just had, a few suggestions that we thought we'd bring up for the committee to consider. So Tom's gonna start with that.
Good. Thank you.
You're welcome.
A lot of good data here.
Thank you.
Yeah.
It was something we really wanted to make sure that we really were capturing, like the risk that we have here.
Well, you have been capturing.
Thank you.
Terrific.
Yeah.
So the first one is section 3, where there's an appropriation
Let
for,
us find it.
okay, for syringe disposal programs.
Yeah, if you wanted that, so maybe Hayden, can you put H222 up, and then we'll follow along up there. Some folks don't use it. Section 3, which is on page 2.
So this has to do with the statewide regional meetings around syringe disposal locations. And then the next section, section 3, is talking about some grant opportunities for people that participated in that process. And the suggestion that we have is just expanding the language about who might be eligible for those grants to say substance use disorder service providers, which is cited in who's going to meet at the meetings with stakeholders, but it isn't mentioned in the second section, the section 3, around who the grants might be able to be accessed by. So the language that I was suggesting was substance use disorder service providers, including harm reduction, drug treatment and recovery service providers. And then I was also suggesting that business owners might be added in there and other community stakeholders, just to try to keep it broad. Because depending on what the community meetings discuss, I know in Chittenden County, for example, Ben and Jerry's has been very active and might be willing to host a site on Church Street, or maybe the Burlington Business Association or Church Street Marketplace. So just having it be a little bit broader so that there's flexibility in who those grants might go to. So, and then 3B has to do with the presentation regarding needle and syringe services, which we support the presentation, but we are hoping to not wait for that report next February before making some progress on expanding syringe services. And this is the topic that I had submitted written testimony about. I have paper copies if anybody wants paper copy of my written testimony.
Yeah, we pass it around and then
Okay.
we'll see how.
Okay.
You have that.
So briefly, what we're trying to raise awareness about is that current law unnecessarily and harmfully limits what types of organizations can apply to provide certain services. So, and then last year, H 728, which passed the House and the Senate, but was vetoed by the governor, reportedly not related to this issue, include a provision that removed the phrase "and which is operated by an aid service organization, a substance abuse treatment provider, or a licensed healthcare provider or facility" from the definition of a community-based needle exchange. And what that would have done would allow other types of entities to also apply to the health department for permission to provide certain services. And so what we're proposing is that same language, same provision be included in this bill. And part of the reason that we're advocating for that is because we feel that it's important that we include organizations that are successfully reaching stigmatized and marginalized populations, so that they might be able to provide these services, since they're more likely to be able to reach those special populations. Examples would be BIPOC community, LGBT+, justice involved, survivors of domestic violence, and others. And VCGR is an example. We serve justice involved people with substance use disorder, which is a population that the health department has identified as having health disparities that need to be addressed. And for example, 82% of our clients reported current injection drug use at intake. 60% reported overdose, as Jess had said. 29% current injection related wounds. And so we're already meeting with a population that needs these services. We have people asking us if we have syringes, and
Just yesterday, we had 2 people that asked because they're struggling, and they asked, do you have syringes here? And, we know that we lose people when we send them somewhere else. People don't always make it to the destination that we're going to. And so, we just feel it's really important that if you're working with this population, you have them in front of you, that you should be able to reach into a drawer and grab, syringes, harm reduction supplies, like you can grab Narcan, like you can grab fentanyl test strips. And we really have people who are asking for that.
And we have very experienced staff. Monica, this is Monica Rivero. She's our 3rd staff person. All 3 of us are Howard Center Safe Recovery alumni, as is Grace. So a lot of safe recovery people here today. And so we have 27 years of combined experience providing syringe services. So we're very prepared and capable of doing that. and we submitted an application, but it was not approved specifically because we did not meet the current definition of being an aid service organization, a drug treatment provider, or a medical provider. We feel that we meet the definition of a drug treatment provider, but the health department disagreed. And so, this change would allow any qualified organization to submit an application, and if they meet the criteria, to not be denied simply because they didn't meet one of these narrow categories of the type of entity. And so that's what we're hoping to have. And just for context, anybody can go to a pharmacy in Vermont and buy syringes over the counter if they have the money. And people that are participating in syringe exchange programs can freely distribute syringes to their friends through their peer networks. And so we support both of those because it's an important way to get the supplies in the hands of people that need them. But why would you then deny experienced providers the opportunity to do the same thing in the context of their work with high-risk people, when we are the ones that are much more likely than a pharmacy or a peer to also give education, also linked to treatment and things like that. And so this, again, this just simply prevents an otherwise qualified applicant from being denied solely because the applicant is not an ASO, drug treatment provider, or medical provider. I wanted to point out that this is not directly related to funding for syringe exchange. This is a separate application process that only gives you permission to provide the services. It does not provide funding or any promise of funding with it. That's a completely separate application. And for example, Safe Recovery, when we first started Safe Recovery, did not get any state support for quite a few years after we started. We were funded through private grants, and we were funded through donations from UVMMC. Emergency department actually donated all the syringes to us for the first few years. And so
It's not necessarily linked to funding, it's just did not
Right,
be denied
right.
based solely off of not meeting those categories.
and
Can I
we
ask a
don't,
question?
Yeah, okay.
So you're suggesting just adding language in section 3B, just about the presentation. So it would just be, they would have to consider whether to, information on whether to provide syringe exchange through. This is just a report to the committee.
right, so what we were proposing is that the language from H 728, which is also in a House bill as well that didn't move, that language that passed the House and Senate last year just be moved into this bill somewhere. I don't know, I'm not suggesting it be part of the report. It would actually take the action right now
Okay,
that would allow other applicants to apply. And so we don't expect any significant administrative burden on the health department. We think that would be minimal. And the reason I believe that is because there have been a very small number of applicants over the 20 years that syringe exchange has been implemented. And so I think that's likely to continue. I think especially since the guidelines are pretty onerous. It's 6 pages of guidelines that you have to comply with. And that includes you have to create and convene an advisory committee, a community advisory committee, and have them meet regularly. There's significant staff training requirements. There's database entry that you have to do in reporting, and there's no funding attached to that. And so we don't think that there would likely be very many applications.
did you testify to this in the House on this bill?
I don't think we did.
We submitted written.
We've written testimony.
Okay.
That's what it was, yeah. And then, basically what I think this would do is allow motivated organizations like PCGR to apply. And I think the organizations that might apply would likely be organizations that are already reaching marginalized populations who they see have an unmet need and they feel motivated to fill that need. I don't think that there'll be many of those, but I think that they could be important. And I know in the House, Representative Small, who works for the Pride Center, had mentioned, that they have clients that there's quite a bit of meth use in the gay community. And also, obviously, there's need for access to sterile syringes for a lot of trans people. And so I think there are just contexts where this would make sense. There was testimony from the city of Burlington about their emergency shelter where they had several incidents there where they might want to do something like this
Yeah.
as well.
So here's what I'm gonna suggest.
Okay,
We hear you.
Yes.
So, are there other suggestions that you would like to, for amendments or proposals within the bill?
yes,
Why don't we just go through those?
okay,
That's what our time is very
Sure.
limited today.
okay,
We're happy to look at the spots that are important.
okay. The next one is section 4B.
Section
And-
4B.
That is, has language talking about the status of legal possession of substances and harm reduction supplies.
Is that little b or big B? Let me see.
Big B.
Big
or
B.
big B.
Yeah, there it is, okay.
And so the suggestion is just to clarify that a little bit more and say, including regarding the relative risks of various substances, the overdose prevention benefits of substance buprenorphine for higher risk opioids, Vermont's allowing for the legal possession of personal use amounts of buprenorphine without a prescription, and the exemption of all harm reduction supplies from the Vermont drug paraphernalia
Do we
law.
have this in writing on our webpage? No.
No, but I will send.
Do you, yeah, you need to send it to us
Okay.
because the ledge council can look at it, and we can
Yes.
look at it.
Okay,
So that's good.
okay.
Okay, just keep going.
Yes.
Yeah.
I think you're,
That, we can be brief on that, section, 6, we just wanted to say that we really support the important changes like related to MedWatch, in this bill, and that we really support, the increasing, to 24 milligrams over 16 without a prior authorization. There's a lot of people that really need that level of medication, and that could really help. And we wanted to, let everyone know that we really support that and think that it could really save lives. Also, access to buprenorphine product, which, can be called Subutex, and it's just a different formulation of buprenorphine. There are a lot of people who, know that works better for them, say that works better for them. It's not dangerous. We know that people are more likely to be in treatment and stay in treatment and be successful in treatment if they're on medication that works well for them. If you have different types of insurance like Blue Cross Blue Shield or something, you can get that medication without any issue. And so we just really wanted to share, that there's been a lot of trouble for people in inducting on buprenorphine with, fentanyl, being the way that it is now. We work with a lot of people who are really struggling to, to induct on buprenorphine, and this medication is easier to induct on. Like the hubs use it if somebody's gonna transfer, from methadone to buprenorphine, and all of these reasons are because it's easier to transition on. And so we just wanted to share that with you because we really need to we need to help people in every way we can to be able to.
So you're talking about page 14, the 24 milligrams of buprenorphine.
Yeah.
Is there any should we distinguish the right kind of buprenorphine here?
so I don't think it would be in that section. And it may not even be,
Something.
this year, but I feel like the legislature has been moving towards
Mhm.
limiting prior authorizations because they
Yeah.
create barriers, and we're just trying to encourage that to continue.
Yeah.
Because, under the current language, there still would be a prior authorization for butte mono product.
Okay.
And that's, I think, the goal that we need to get to, which may take some time. So we're not necessarily saying that needs to happen this
Okay.
year if that's not what the committee is intending, but we're just encouraging you to keep the focus, because the concern, to be honest with you, is that this is something that the legislature has had to spend time talking about for a few years, and we don't want momentum to be lost. And, so there's still room to make some more progress next year.
Okay.
I think that the language that's in here was a carefully
Crafted
crafted negotiation, and I
Right.
don't want to mess with it.
Right.
And on a number of these items that you're
Yes.
bringing up.
Right. You're, yeah.
So,
We'll have our discussion. We'll
Okay.
look at the
Um,
language. But
We are very supportive of the language that's in there related to all
I
of
just
that
don't want to,
stuff with
I don't want
puberty.
things, fall apart.
Yeah, no, neither do we, no.
We'd like to see the bill go all the way through.
Yeah.
Oh, of course.
Yeah, we would
We
as
do
well,
too.
yeah.
Okay, so the next one is section 10, the sunset provision relating to beef parking.
Yeah.
Do you want to hear testimony about that or no?
Well, you're talking
In
about
support of it? we're
in support of
supportive of it.
taking away the
Yeah.
sunset?
Yes.
Yes. Are you supportive of it?
Yes,
Okay, that's all we need.
Okay.
We're very supportive.
That's
you
good.
just saved yourself
I
2
suspected
pages.
you might. But, please do send your
Okay,
comments
okay.
and the legislative recommendations.
okay. And then, we watch you guys on TV all the time. And so we're aware that there's been some conversation about possibly adding opioid settlement funds to this bill. The most recent version that we saw didn't have that. But if it's okay, Jess, who was part of the committee, was gonna just make a couple comments on that aspect.
Or you can do it quickly.
Okay.
And because we want to save, I know we have other folks
Yes.
waiting to testify, and we also need to consult with our ledge counsel, so.
Okay,
I'll be brief. I just wanted to say basically we are definitely in support of getting the money out the door as quick as possible with that. And it was really great to be a person with lived experience being on the committee this year. The main point that I want to make about the opioid settlement funds is that a few of the recommendations are very limiting in like who can apply for them. Like the outreach workers is very specific to the preferred provider networks. And there are people, like us and like others, domestic violence shelters and, other homeless shelters and people that work with specialized populations that really could use, a case manager, an outreach worker. We also we're hoping that the outreach worker definition, or that could be expanded to say outreach like / case management. Being a person that works with people who are struggling every day, that's probably one of the hugest needs we have. Yes, we need to reach people, but we have to go farther than that. It's not just about reaching them, it's about what do we do with them once we have them, and we need to really capitalize on bringing people in and then bringing them into services and then helping them connect to all of the things that they need to connect with. And right now, I just think it doesn't really clearly kind of spell out that would be, the use of the funds. So I wanted to share that because there's a lot of need for the case
So
management.
we get it. We understand that there are a lot of things that haven't been addressed in this first goal, in the first,
Yeah,
hate the word tranche,
yeah.
appropriation. But, and we know that in the future, there'll be more funds available and greater consideration given to expansion rather than just, narrowly supplement. So our goal in this committee has always been to include as much as we can from the advisory committee and have it move forward as quickly as
Yeah.
possible. So the money gets out the door and we begin to see it used.
Absolutely.
So, but thank you for your comments. This is helpful.
Yeah.
And it will be very helpful going forward for you and the rest of the advisory committee, as well as us. So appreciate it.
Thank you.
Go
Can I
ahead,
just make
Senator.
a quick, well, first of all, thank you guys. And for anybody who hasn't visited BCGIR, you should definitely visit. They're doing amazing work. I had a great visit there and
Thank you.
Jess was a really valuable member of the opioid settlement committee, provided a lot of really important perspective. And so I just want to put a plug in for the great work they're
Sounds
doing.
like a field trip.
Yeah, it's definitely
Yeah.
impressive. I mean, it was really impressive what they're doing with, especially with now I'm looking at
Contingency
contingency
management.
management, thank you. And I definitely, Jess's comment just now about the case management versus outreach, I do think that would be a small change that we could make in that language if we wanted to. It's a small, but
Well,
kind of valuable
I'm looking
distinction,
over
but
your
yeah.
shoulder at the Department of Health and seeing that that's probably something we could do. And if there's
Yeah.
agreement on that, it's important to have agreement, so.
yeah, I completely agree.
Yeah, good, let's do it.
Thank
Okay.
you. Thank you so much. I really
Yeah.
appreciate it.
Senator Rulick has a question.
Of course.
Thank you very much for this. This has been really interesting, and I saw you speak last week at the.
Oh.
It was great.
Thank you.
You didn't mention drug checking. Is that something that would be important to you?
We, so we definitely support drug checking. We, you know, to be honest with you, I think that we would like to see drug checking included in here, but, you know, in terms of just getting the message that the bill is kind of getting to the end stages, and
What we're
you know,
hearing here.
what we're hearing, you know, what we're hearing here and outside of here is that maybe that, you know, we shouldn't try to be imposing that at this point, but we do support it. And the same thing with overdose prevention centers, you know, like we would love to see some money in for building capacity in Burlington and Brattleboro, just to get that process started, have, you know, community stakeholder meetings, have some planning process, that kind of thing. But we just, you know, we had a lot to cover, so we, you know, we just didn't include it, but yes, we support that.
Thank you.
You're welcome. Okay, thank you.
Thank you so
Thanks so much.
much. We really appreciate you
And
having
so
us.
we're gonna move right on to Grace, please.
Yeah.
Great.
I
After.
appreciate that.
Yeah.
You're in luck because I've worked with these two for 17 years and we've never disagreed on a policy. So ditto to all of what they said.
A lot of history in this room.
Yeah.
Great,
Exactly.
yeah. good
Well,
work.
that's the interesting part about harm reduction is we all are on the same page,
Yeah.
even working together every day. So my name is Grace Keller. I was the program coordinator at Howard Center Safe Recovery, worked there for 15 years. And I recently last year left, or in August left to go back to school. I'm going to Brown for my master's in public health.
Excellent.
So this is the first time I've been in front of you all without asking for money, which is really nice.
Wait, are you doing that remotely or?
Yes,
Yeah.
yep, which is it's really a neat program. But what I'm here about is H222. Also, I'm the chair of Vermont Overdose Prevention Network, which is a group of people from law enforcement to the medical community to harm reductionists. And we're just really focused on saving lives. So I have a couple additions and a couple of comments. One of the things at Safe Recovery that we started in the last couple of years was a low barrier buprenorphine program. We really struggled with funding and we applied for a federal grant and somehow got a SAMHSA grant through the Trump administration to start a low barrier buprenorphine program at the Syringe Exchange. It was one of the first in the country. And one of the things I really want to drive home, having been a leader on the front lines, having been on the front lines, is I've talked a lot about people who are dying and the people we know. And when you talk about only 25% have been touched, I tell you almost every time we see an obituary, one of the three of us or four of us knows them. So I do think that there are people touching them. We just need to get to support that. It's people that are anonymous, like a Syringe Exchange. It's domestic violence shelters. It's those kind of things. But one of the things when we started the low barrier buprenorphine program, I never imagined is that we were putting the front lines in positions that they never imagined they'd be in. My staff and myself included, I felt like we had to discriminate against people who have opioid use disorder because of what we're talking about in here, which is the prior authorization. And I know that sounds extreme, but I'll tell you a quick story. When Kim Blake, I don't know if she's testified in front of you all, but she was the doctor. And we're talking here just a little bit about the MedWatch. So one of the reasons I'm driving this home is it really needs to stay. It does come up and here and there, and then they say, oh, it doesn't exist, and then it reappears. This is an example. One of our clients came out of jail. The jail uses mono product exclusively, other than methadone. And he said, I've had hives and I've broken out in hives every time I take Suboxone. And to get him, so if he was on Blue Cross Blue Shield, we write a prescription, we give him what he needs, we tell him. To get him through Medicaid, we had to tell him to go to the pharmacy, pick up a tablet, come back to our office, which is not a medical office. It's a building on Clark Street, take it in front of us and sit there and wait for him to break out in hives. We don't have an EpiPen. And he did, broke out in hives, his whole trunk. Then he had to lift his shirt up and we had to take pictures of him and send them to the state. That is what's happening. So I know it's like, it's the I'm never the sunshiny person at these things. I'm not good at parties either, just so you know. But that's really what's happening. And so when it comes and it goes and people say, oh, it doesn't happen. That one story is bad enough. That story happens over and over and over again. And again, if Senator Lyons walks in and she's got Blue Cross Blue Shield, I say, have you taken any of these before? Just like your doctor does with antibiotics.
Right.
But if Senator Lyons has Medicaid, we have to say, you really have an allergy? Are you sure? You know, and forcing someone to break out in hives, I mean, didn't stop breathing, but hives are horrible, you know, and in a non-medical setting with a doctor. That's what we're asking. So that's one of the things I just really wanted to drive home is I can't live with that. And I can't, you know, the state has good intentions on some of these things, but they don't picture the person who has to deliver them, and they're really traumatizing. So I will keep trying to move quickly. What they're talking about with the expansion of SSP, we have people that are willing to.
You better define your acronym there.
Oh, syringe service programs.
Thank you.
Actually, in class the other day, they were talking about when you look at policy, just ask yourself 2 simple questions, and it seems really basic, but is it stigmatized and is it arbitrary? And I think we are looking at a lot of, you know, if you change out addiction or substance use for any other disease, you never would have to do that. You would never take a cancer patient who said they had a reaction to chemo and make them try it again. And so I think that that's where we're looking at some arbitrary guidelines. We had a group in Brattleboro that wanted to do peer support syringe exchange. They were not approved. They weren't even able to really apply. They had funding. I don't think we need a chilling effect on these services right now. I think anybody who can get to these folks, endocarditis at least 10 years ago was $600,000 if you need a heart valve replacement. That's one case. And that's happening all the time. So that's one of the things I really want to talk about. That's something also we should focus on is people who have these wounds, which xylazine is really getting there. Jess and I had a client who had a wound on her leg that we couldn't have covered with both of our set of hands for 2 months. I mean, people are enduring really horrible things because they're afraid of the emergency room, they're afraid of consequences. So we really need to be getting to people. And finally, we had a doctor on site where we said, you say the word, we'll get you to see him or her. And finally she did, but the fact that she didn't lose her leg, I've never seen anything like it. I've never imagined anything like it. So those are the couple of the big issues. On drug checking, I would say, and I'm a bit of a free agent at this point. I would say that that's something that we really need to look at and really should support. The only way that people are going to be able to prevent overdose right now is to know not just what's in their supply, but how much of it's there. And I think when I looked at the statistics from VDH, 93% of the people who died of overdose in 2021 had fentanyl in their system, and less than 10% was heroin. So we have a fentanyl supply at this point. We do not have a heroin supply. And looking at Rhode Island and seeing what they're doing right now, it almost feels like it is an equity issue that people have services there that they don't have here. People have services in New York, and not just the clients, which I've talked about and I have way too hard of a time talking about, but our staff, our frontline staff is suffering. You never imagined that you'd see a couple of us leave Safe Recovery at some point, and we all did recently. And it's not more than anything, it's just, trauma of the front lines. I think I've told this story before, but not here. One time we had a client who came in and said he had a friend overdosing in the car. He had seen the person on the street pick them up. So Tom and I went out, and the person was blue, not breathing, and he had a dog in the car. So I administered Narcan and I started rescue breathing, and the dog thought I was trying to hurt him. So the dog was coming close to my face and almost biting my face for the entire 7 or 8 minutes that we couldn't get a whole handle on the dog. And so when we talk about things like overdose prevention sites, this is what's happening on the front lines. And the message that the clients are getting is don't tell anybody until it's an absolute emergency. Mm-hmm. I've been to Vancouver. I luckily went and got to see the overdose prevention center there. And it was emotional because somebody goes out and they're on it. Within seconds, they know. For us, I've
It's
revived it.
amazing.
It is
Yeah.
amazing. It's instantaneous. And I've done rescue breathing and I've reversed over 25 overdoses. And all of it has been luck that that person got to me in time, that I got to that person in time. It's only happened once where it happened on site at Safe Recovery. Otherwise, it's somebody bringing them. And even being sober at work, paying attention, being an expert in this, you don't know how long it's been since somebody's been in that state. So we're also putting the front lines in a situation where they might watch somebody die. And I do have very serious concerns about that. I was looking through the Rhode Island stuff for school and I found their health department's brochure on overdose prevention centers. And so I can pass that around if you all want it, just to see what other states are doing. I don't have a colored copier, so it's a
That's
little.
okay,
it
so
looks
do
like
pass it
that.
around, and then if you, are there specific comments that you've sent us on the legislation, or would you have something?
No, I haven't sent you anything on that. I wanted to just make sure, you mean on 222?
Yeah,
Yeah, I
yeah.
haven't
Okay,
sent that, but I will.
but overall, you're supportive of the bill,
Overall, I'm
And-
supportive of the bill.
but you've asked to have things go forward a little bit more.
Yeah, I do say in my heart of hearts, and if this wasn't about life-saving stuff, I would be more diplomatic. Looking at the recommendations from the committee for the overdose settlement funds, and I put Jess on there in statute. I actually got to pick who should go, so one of the best ideas I've ever had, but when I close my eyes, and I've been through losing so many people, and last night when I was thinking about being here, I'm just worried that we don't go far enough to save lives in both the bill and in the,
So, and there's a
And the
lot, there
recommendations.
is significant frustration, I think, in this building and in the community about what we can and what we can't do, and why aren't we doing more constantly? The value of the prescription drug settlement is that we can look forward and know that all these things that are giving us frustration now might be responded to. And, I think everyone has that sense, might have slightly different timelines and ways, but certainly supportive of what you're thinking and saying, I think.
no, thank you.
Yeah.
And I think one of the things I just want to keep in my mind is is it arbitrary or is it stigmatized? Because there are times where we're tying our hands, having restrictions on who can provide these services and having, there's just a very prescribed way that, and then sometimes down the road, we realize, oh, we messed up. We don't want to have a chilling effect if people want to do this work. Especially I think Tom pretty much wrote the bill for syringe exchange and started it. This is the crowd of people that they should be able to do that. And things like endocarditis. I mean, $600,000 for each patient, potentially for each patient. That's a lot of money.
A lot of prevention.
Yeah, so I think that's the main thing. I really would say drug checking. I think we need to empower people as best we can. I mean, these are the middle of the road stuff I have. I have stuff that goes a lot farther than this, but I think to save lives, we need to really do what's evidence-based, do what our neighbors are doing, and really focus on the life-saving part of it. I appreciate all the work that the committee's done. I just think we need to go a little farther.
Thank you very much.
Thank you.
I just want to express a little bit of frustration as someone else in this committee that I'm not aware of all of the negotiations that have gone on behind the scenes, because I'm hearing really compelling testimony, and yet it seems as though we might be limited as to what we can do. So at some point, I would like to be
So
In
here's
on
what,
knowledge.
I think the question that's being asked is, the advisory committee has made recommendations for the use of a significant amount of money from the federal government. We do have that memo on our webpage. So the frustration I think you're hearing is, why aren't we taking some of that money or some of the money that may not be appropriated suggested for appropriation at this time? And why don't we use it for the testing? I think that's the biggest message that I'm hearing. So the question is, do we deviate from the path of the advisory committee that has done a lot of work over the summer and the fall and add this in and send it down the hall, or do we stick with what's there? I think that's the biggest piece that you're hearing. There are other small changes in language that we're also hearing and that we'll look at.
I also just think I haven't been given all the information to make informed decisions at this point.
Sure.
Thank you, Madam Chair, and I'm happy to have more conversations with you, as someone who's been working a lot on this. One thing, so for context, for last session, there were 2 harm reduction bills that were vetoed by the governor. And so I think it's important to understand that we're trying to find a path forward that will not be vetoed. And also that respects and honors the work of the advisory committee that Jess and I both served on, and many others, and the hard discussions we had there to come to an agreement. And it was a unanimous agreement, and there were certainly many of us, including Jess and me, who wanted to go further and have more things in it. Drug checking did make the list. The one concern was the immunity protections that are required with drug checking. And I am completely in favor of moving forward with drug checking as long as we can find a path through this building and get the support of the health department to make sure that we can move this bill forward. Because the most important thing is that we get this bill, which is a huge step forward, and it doesn't include everything that many of us in this room want, but it is a huge step forward compared to where we were a year ago. And it will save lives. And yes, there's a lot more to do. I'm in favor of all the things they all said. But I just want to make sure that we don't put something in this bill that's a poison pill. And I think that the House worked really hard to come to an agreement with all the people about the pre-authorization stuff, about the syringe service organizations, about what the language is in the bill. And there's certainly tweaks that we can make, but I don't want to deviate so far that we take it off track and it gets stuck over there in the House or gets vetoed. So that's why I'm being cautious, even though generally I'm the one that's pushing.
Gotcha.
So, yeah.
And I hope I didn't insult you.
No,
or the
not
committee
at all. Not at all.
No, the
Grace, you're
advisory
fine.
committee did a lot of work,
Yes.
and we've had this come into the room in other ways, and other bills where, for example, on, I remember which one it was, S47 perhaps, yeah. Where there was a group that worked outside, and then later on, folks came in to inform us about something that wasn't included, that the group had looked at but had rejected. And that's what we're hearing today. That's okay, because it helps prime the pump for the next time. And we really appreciate the expertise that you each bring into the room. And thank you, Senator Hardy. That was a good reminder of what we did and what we did last year and the results of that.
Yeah, and there are other avenues to other vehicles. There are several other bills that are still potentially in play. Plus there will be money for some of this in the budget as well. So there are other things happening too.
And I figured I'd put it out there and throw everything in and see where, but it didn't have to be in this bill necessarily. And I'm very grateful. I have a lot of time on my hands sometimes, and I watched all of those. But I do, yeah, I think I've also not been a free agent before. I loved working for Howard Center. I loved having grants through the health department, but this is the first time that I'm like able to just really say what I think. And I think also just knowing how many people that we've lost.
If we can get some of what you think in writing,
paper,
that would be
you sure
terrific.
can.
Thank you.
Thank you. And, I'll give you a couple of these too. This is for the Overdose Prevention Network. It's our position paper.
Great.
Thank you so much for having me.
All right. So
Yes.
good luck.
Thank you.
Round.
Thank you. We'll
That's
see.
so great.
It's been since the 90s, since I've been in school, so we'll see. Things have changed quite a bit.
No kidding.
Yeah. Well, thank you very much.
Thank you.
And thank you for all you're doing.
Katie, I'm gonna ask you a question. Are you available for a longer period of time? I think we might I want to ask David Englander, Department of Health, if there's a comment that you'd like to make, and Katie then if you have time to meet with us, I know that Jen Carby is outside on H190. I'm just trying to sort out what we can do with our time
Sure,
before 11:30.
Yes, I think that's fine.
Are you good?
Yeah, I'm checking my calendar, but I think I'm okay. I'm okay.
All right, that's good. David, did you want to make any comments about some of the language suggestions that you've heard from folks, or?
For the record, I'm David Engel, the Senior Policy Advisor to Department of Health. Not off the top of my head, I would be happy to be a resource to the committee if they choose to move forward with some of the language.
Okay, that's good. I think we'll do that. Now, we have asked Katie for some language, and the hearing today, there might be a discussion that adds others, so it'll be good to have your input on that.
Can I
Go
ask
ahead.
David? You're not in the witness chair, but I'm gonna pretend you are.
I mean, you know, sure.
Yeah, or Katie's chair. The drug checking language and funding, does the department have, I know we talked about this, does the department have a position on that? And also any changes in the language regarding syringe service providers? If we were to tweak either of those things, have you discussed that with your boss?
Yeah, well, so as you know, and I believe the memorandum is on the,
Yes.
no, we talked about it in the House, the full list of things that the department. I don't, we would want to talk about I don't think we have time about the open settlement advisory committee, but what the department did in brief was say, trying to get our arms around the universe of possible measures, and we put out dozen, 30 or 40 different ideas, including drug checking.
Yeah.
So that is an idea the department supports.
Okay.
The complexity was, as you articulated,
The
the community.
So if we were able to figure that out, the department would support it. Okay, that is good to hear on the record, even though you're not in the witness chair. But what about the syringe service provider? I know that was a sticking point last year. You heard what Tom was suggesting. Where are you at this year with it?
So we continue to have concerns about tweaking the language.
Okay.
And I can provide more fulsome testimony at a later.
So anything you can get us in writing would be extremely helpful.
But you're okay with the case manager adding that word?
Yes.
Okay.
Oh, good. Thank you. We got one.
And drug checking,
too.
we have one more person.
No,
No,
we don't.
I'm-
No, Katie, I'm gonna ask you to come up for a minute, and then we're gonna, we might, talk with you for a minute, and then we'll come back to you again.
Okay.
I think you've heard the request on behalf of the Vermont Center and, oh gosh, VCJR. And we also, I think Senator Hardy and I separately and together asked for a proposal amendment. And do you have something that we could share with the committee?
Sure.
And look at, okay,
Although I don't have my screen on, so,
okay, do you want your screen?
yep, let
Can
me,
you give her screen?
hold on, I have to. I'll leave it Shirley. So what we'll be looking at is instances of amendment.
Okay,
That may change if the committee moves in a direction with more changes, although what you're talking about at the moment seems sort of discrete. So here I am. Okay, let me see if I can share. Okay. Okay, so this is the amendment that I started putting together. There are a couple instances of amendment. The first instance of amendment, I believe, had to do with a proposal made by the Department of Health. And that is in section 2, where we're talking about the stakeholder meetings. There was reference to the Blueprint for Health's accountable communities for health. And the suggestion was to remove accountable communities for health. So this has the effect of making that read only Blueprint for Health. The second instance of amendment amends special funds language. So last year there was a bill that went through to create how to address the settlement monies that were coming into the state, and a special fund was created and a process by which the working group or the advisory committee would meet and give recommendations, and those recommendations would move to the General Assembly and move through the process, was all dealt with in that bill and is all in statute. However, the language mentioned that the department, meaning the Department of Health, would be submitting this spending plan as part of its annual budget submission. And as you know, that is not the process that's taking place right now. So instead, the language is being changed to say that the language is being submitted to the General Assembly. So a little bit broader to give a little bit more flexibility for how the spending plan actually comes to be before you. So that is change there. And then section 12, a new section 12 in the bill would be one-time appropriation of money from the special fund for the following purposes. So we have, where am I? We have $1,980,000 for the expansion of naloxone distribution efforts, including establishing harm reduction vending machines, home delivery and mail order options, and expanding the harm reduction pack and leave behind kit programs. So I should say, these are all the items that were listed in the memo that you have, that you received, and that's posted on your website. Next, you have $2 million divided equally between 4 opioid treatment programs to cover costs associated with partnering with other healthcare providers to expand satellite locations for the dosing of medications, including costs associated with the satellite locations' physical facilities, staff time at the satellite locations, and staff time at opioid treatment programs to prepare medications and coordinate with satellite locations.
Can I ask a question? I think Senator Hardy, probably you could answer this, Jess. The determination for the satellite programs was based on greatest population based needs, or?
It was based on a couple things. One, where there are no sites currently.
Yeah.
So there are no sites between Rutland and Chittenden County. So that's Addison
Rutland
County.
does have one. That was.
Rutland has one,
but-
Chittenden County has one. There are no sites between Brattleboro and the Northeast Kingdom. So that sort of in between section, probably Windsor-ish, Orange-ish County, somewhere in there. And then Chittenden County has an overflow of a waiting list and is turning people away, as you heard from Jess. So having another one in Chittenden County, and then Department of Corrections,
Right.
there's clearly a need there, and they, the Commissioner of Health checked in with them, and they thought it would probably be in the northeast. I can't remember the
Northwest.
Yes,
Yeah.
but they said we just left it vague, so it could be whatever Department of Corrections site they most needed. Yeah.
Okay, thank you.
Can I add one thing? I would say the Chittenden County one was also like, I think we put a little flexibility in the language because like that it didn't necessarily have to be a satellite location, that it could also be used at that one site to expand hours because they have so many places, so many people miss their dose every day. And a lot of people, you know, don't have access to a dose, putting them on the schedule dose that day. And so like I hope that, you know, it can be used to increase capacity that way too.
Yeah. And there was talk about in Department of Corrections that corrections could move people who specifically needed the treatment to whichever facility they put this hub in. And also the balance, we had a lot of conversations about the balance between rural and urban, like serving Chittenden County, but also wanting to
Geographic distribution.
Yes.
Good, thank you.
Okay.
Go ahead, Katie.
So in subdivision 3, $1,976,000 to fund 26 outreach staff positions within the preferred provider network and within syringe service organizations for the provision of services that increase motivation of and engagement with individuals with substance use disorder in settings such as police barracks, shelters, social service organizations, and elsewhere in the community. And then $240,000 divided equally among the state's 4 syringe service providers to provide overdose prevention services and response education and resources that build trust between individuals with substance use disorder and Vermont system of care. Subdivision 5, 84,000 to provide contingency management services to individuals with substance use disorder. Subdivision 6, 100,000 to implement a wound care telehealth consultation pilot program for the purpose of utilizing wound care experts to provide telehealth drop-in appointments to address syringe use by individuals with opioid use disorder. And lastly, 200,000 to expand the distribution of fentanyl test strips and, if available, xylazine test strips. And then we're just reordering the last sections to be in order.
Okay, so we have other suggestions for language change.
Okay.
And Tom, you're submitting. Are you submitting anything?
I'll submit testimony, but probably not, I mean,
Okay,
I agree with this language change, support it.
okay. And then David, some acknowledgement of yes or no on some of the suggestions that you've heard today. So we can bring those all together. And when you make those suggestions, please copy Katie
Yes.
and Nolan.
That's what,
Yes,
for the record, just informational.
yeah,
That money that Katie just walked through equals 7.336 million.
Yeah.
Just so you have a number. According to David, there's 10.4 in the fund currently.
so suggesting that there's a little over 2 million something left that is not being appropriated or suggested.
So this is David Engler, so there's several million left over so so there's roughly 10.4 in the bank. 7.3, so there's significant headroom left. The issue is that there are a number of settlement funding streams.
Yes,
And some of them are front loaded and some of them aren't. And so most of them are 18-year or 18-year zoning period. So I think we want to make sure that the funding is sustainable at least for the life of the project. So we don't want to be spending, every dime comes in.
And to add to that, remember, you're also increasing the manufacturer fee. So you actually have
Right.
another 1.3 million in the bill that's not being spent as well.
But not all of the uses, the allowed uses are the same.
Correct.
oh,
They
yeah,
have specific allowed uses.
So is may I ask David,
yeah,
Or Nolan, the increase in the fee that funds some things, is that different than what is allowed under the settlement fund?
Yes, those are two totally
They're
different.
totally
Yeah.
different, so it's not like one could replace the other.
No.
I mean, there's language on it.
So in the Venn diagram, there are overlaps. For instance, the virgin distribution of the water center
Okay,
can come from either that section's fee or the settlement funds.
but
So yeah,
otherwise they're different.
yeah, an issue brief on it, and we'll tell you what the allowable uses of the fund are.
Of the
of the manufacturer's fee.
manufacturer's fee, did you get that close?
And that's something that,
Can we make
that,
copies?
that,
Can I give it to?
Yeah.
I'll,
yeah, it does say,
but yeah.
or you want
yeah. And appropriations will be looking at this and sorting out what fits for expansion or supplementing what we currently have. And then what can go elsewhere because it's not supported by the guidance documents or one or more of the prescription drug settlement programs, the process. So Katie, that's it, I think, for now. I think, committee, are you folks okay with including the advisory committee recommendations and funding? It's not funding that comes from the general fund, it's funding that comes from the lawsuit.
I'm in favor.
Good, okay, so we'll keep that in, and then we'll look at language, you'll bring it back to us. I had some requests this morning from members of the House who were interested in having immunity included, as well as a definition of buprenorphine, and I'm not certain that the immunity provision would allow for the bill to flow freely through the Senate, so it may be
This is for
something.
testing.
Yeah, so I
Yeah.
think we may,
So this will be Michelle that's going to write.
yes, but I'm gonna suggest that the committee, please consider the immunity piece. I'm not asking you to put it in at this point at all.
Okay.
And we are taking this up again on Thursday morning.
Yeah.
Excellent.
We want to get this bill
Thank you,
settled
Madam.
so it can move quickly to appropriations. In particular, the 7.3 million that has been pondered over by the advisory committee for many months. And, but we don't want to do anything that is going to keep the bill from,
We need to find,
that needs to go to finance.
Oh,
first.
really? Oh, shoot.
because of the,
Oh, because of the fee. Well, maybe well, let me deal with that one. No.
It'd be nice to not get it stuck there.
But the manufacturer's fee is something that's indigenous right here. It belongs to us. So I will talk with the finance committee, see what that means. Okay, thank you. We're gonna take a 5-minute break.